I guess the simple answer is that some of these results determine treatment choices. So in a patient who's never had treatment before, some of the simpler genetic tests that we do can help determine what kind of chemotherapy and the intensity of chemotherapy and what our approach is. It also, as Piers has indicated, can help refine exactly what the disease is that we're looking at. And so that means that over time, when we look at how we've treated these treated patients, we can understand better what the outcomes of our treatments are as a group. But the most real example is when you find mutations that you can target with novel drugs. And we don't use novel drugs usually in the frontline setting, except for some of our more recent immunotherapy studies. But in patients whose lymphoma misbehaves, there's an opportunity to use novel drugs. And the most sort of pressing, the example that comes immediately to the top of my mind is a trial that we're doing at the moment of a EZH2 inhibitor, which is where we deliberately use a tablet to target a mutation that occurs in some forms of lymphoma called an EZH2 mutation. And because we've been able to integrate this sort of genomic testing into our routine care, we're able to think one step ahead. And so I've had recently an unfortunate patient whose lymphomas misbehaved, where I knew before the lymphoma misbehaved that she had this mutation. So when it did relapse, I knew that I had a broader range of treatment options than I might have had we not done the sequencing and had Piers not been one step ahead and provided me with that information as I needed it. So it's really important, particularly for some patients who are more unlucky.